Hi, as I said earlier, my name's Eve Baker. I work with 3 CCGs in the East Berkshire who work in Federation. That's Bracknell and Ascot CCG, Slough CCG, and Windsor, Ascot and Maidenhead CCG. And really what I'm going to take you through was a bit of a journey that's happened in our area and try and answer some of the so what questions. One?
Yeah.
So I'm going to brief history, how one of our CCGs has taken a real leap forward in the way they use this the population analysis, and then how we're using risk stratification within a big strategic development that we're doing locally called New Vision of Care. So we put ACG tool in some time ago in the PCT days, and as Steve was just saying, the introducing the data sharing agreements was a huge hurdle to overcome, and that was a real significant first step for practices. But once we did that, we put some support into getting practices rolled out on the system, and that worked well. But what we found is that the use of the tool was really quite patchy, and it depended a lot on the sort of level of interest that there was in the individual practices. Practices needed quite a lot of support, and in retrospect, we probably didn't put enough support in to really support that process. And also what we didn't do was really to start to look at the population level data. It was really much more about practices using it to case find. We found that when they did do that, it was linked to integrated care teams around clusters of GP practices. When they found the patients and then they were taken on by the ICT teams, when we looked at those individual patients, there was massive reductions in the level of admissions and use of consumption of resources for those individual patients. But we weren't seeing the population benefits. Overall admissions were continuing to rise, and I'm sure this is sounding familiar to lots of people. So, I've done some of that already. So I've said quite a lot of that. So just to repeat that point, we were not analysing the data at the population level and really not fully exploiting the benefits. So Slough CCG, post-authorisation, of our 3 CCGs, they're the most sort of data interested, and they've really taken a step forward with this. So what they've done is they're looking at planning proactive care with a Better Care Fund, which targets care to the population at the highest risk. So they've agreed with practices to release anonymised data to one individual in the CSU, and clearly that's part of the sensitivity around this. And then working with the CSU, working with the clinicians, the CCG managers, they've done a lot of analysis with the data and done sort of comparisons at practice levels and at population levels. And they're now starting to use that data to inform the way they target services to populations at the highest risk. So what they did, they started to use the routine case management report, and then they further segmented it by age bands and the number of chronic conditions that patients had. And one of the revelations for Slough, whereas the received wisdom is that it's always age that drives things, that's not true in Slough because of the particular profile of the population. They were finding that much younger age groups were consuming higher proportions of resource. But they started by looking at those 2 particular segments, and I'm surprised nobody's put up a risk diagram yet, but I'll put one up. So we all know, don't we, that it's the top sort of 5% of our populations that consume, in Slough's case, sort of 32-33% of resources, and I'm sure we could all put up profiles like that. Then at a practice level, they could see that morbidity, it really wasn't distributed evenly, so they started to understand the profile of that across their practices. And the risk of emergency admission is also not distributed evenly, so they started to understand that too. At the beginning of 2014, they worked with Johns Hopkins to put in an additional predictive model into the UK version. So this model predicts the risk of emergency admissions in the coming 12 months. And they work with Berkshire, Buckinghamshire and Oxford GP practices to formulate that new model. So prior to that, most people were using the model to predict the likelihood of patients being in the top 5% of the most expensive patients in the next year. Slough now predict those most at risk of being high cost and those most at risk of an emergency admission. So how this helps them target resource? They're really starting to refine their understanding and use of this data and identify relatively small numbers of people within each practice who have those risks. What they've then further done, they're starting to identify key combinations of conditions that really start to show high risk. So what they're starting to do is to be able to boil it down to quite small, specific individual people within each practice by sort of going back up to a population level and coming back down to the practice level. They have quite manageable lists of individuals that they're starting to work very proactively with by looking at those parameters. So then they can put the right level of interventions in. So the conclusions that they've come to and their findings is that very small numbers of patients, as we know, account for disproportionate use of resource. The future risk is driven as much by multimorbidity as age, but that people of working age in Slough contribute as much to cost as those aged over 65, and also as a high risk of emergency admissions. And there is a really significant variation in case mix between practices. So the ACG system can be used to identify those patients most at risk and consume the high level of healthcare costs in the year, but the sophisticated filtering system that they use finds the cases that the clinicians are most interested in, and that's really engaging the interest of the practices. And although it's early days, the early adopters are really starting to show some very interesting results in this. It's too early to start really seeing it in the graphs and everything, but this is looking really interesting. So then I'll talk a little bit about new vision of care. So we're not a vanguard in East Berkshire, but we're doing work as everybody else is. So our system leaders groups decided at the beginning of 2015 that we would start to look at care for elderly people and people with multiple long-term conditions across health and social care. So we've come together as 4 CCGs, the 3 in East Berkshire plus Chiltern CCG in the south of Bucks, 4 local authorities, the bigger Frimley Health as the acute provider, our community provider, the ambulance trust. So everybody within the systems come together, and through working with a design group drawn from all of those organisations and working with our patients and public groups as well, we've come up with a model and vision, which we've called New Vision of Care, which I'm going to share very briefly with you, and show how risk stratification and case finding fits into that. What we're going to do with that model is to take it and there's a bit of a contrast with the North East Hampshire and Farnham approach here. What we're going to do with that is we're going to create work streams from the vision which do 2 things. They will first start to build infrastructure, so where we decide we're going to use risk stratification, what we're doing with shared records and those kind of things. But we will be coming out with exemplars and outcomes that we want at each of the stages of the vision. And then it'll be down to individual localities to react, to deliver those exemplars and those specifications and those outcomes in the way which best meets the needs of that local area. So it's a slightly different approach, but equally valid, I'm sure. So quickly to go through this, we've described the 7 stages of somebody's life, starting from where most of us are now in that self-care and prevention arena, right through to end of life. We understand it's not a linear process. People will pop up in different areas, and our whole emphasis is pushing people back down that way towards independence. Within that, we understand the features of that, so people, family and carers, multi-skilled teams, what's available in the local areas and what can be provided at home. But also having that in-reach and outreach from specialist care and really, really good hospital services. A number of features. So real prevention at an industrial scale, information and multimedia signposting, identifying those who need care by using shared risk processes, case finding and shared assessments, single care plan with formal care planning processes, delivering those care plans through using agreed protocols and processes, coordinating and monitoring that care, and enhance services within each of the localities. So those are the features of the model. I apologise, I'm going at some speed. And these are the enablers. So key enablers around shared information, collaborative leadership, workforce development, and things you'd expect to see. Gives us that lovely sort of integrated whole. And you can see that our strapline towards better health and independence. So it's about people having more responsibility to stay healthy. So how does risk stratification fit into this? In developing the model, we did quite a lot of work with Professor John Young, who is now Sir John Young, who's National Clinical Director, and he's done a huge amount of work looking at frailty, and he really advocates that we need to treat frailty as a long-term condition. It satisfies all the usual criteria for being treated as a long-term condition, and that's what we should do. And in so doing, we would then be much more proactive in identifying and treating people before they tip into more dependency. So he talked about a number of ways we might do that. Case finding from routine data is at the bottom, and that's what we're here to talk about today. But also really important are things like comprehensive geriatric assessments, but also a lot of simple assessments. And he talked about gait, speed, timed up and go tests, and things like that. So that one, if you want to see a little bit more about that, is really interesting. So we know that if somebody takes more than 5 seconds to walk 4 metres, that's a really high predictor of future frailty. So that's a really simple test that can be done in every GP practice, every community setting, can be done in the home. Identification of frailty using existing primary care data. So it's about constructing a frailty index, which is another thing which is starting to be available. I think Vision are starting to develop this. This is really based, and I think I've got this next slide. Yes, it's based on a deficit, what's called a deficit model. So the way the index works is there are a whole range of read codes which identify a deficit, if you like, and the combination of those enables you to work out the frailty index for individual patients. And they lobbied long and hard, and the Information Centre developed some read codes for frailty. So now, once these patients have been identified, they can be properly coded in primary care data. So to build that back into a new vision of care, what we're looking for is systematic and consistent identification of those at risk using all of those features. So use of evidence-based tools from self-assessments at home, assessments within the local community, identification at GP surgeries or by the hospital specialist, and use of information to case find those who are showing signs of deterioration. That then needs to be linked to systematic care planning. Resource can then be targeted to avoid people going into crisis and losing independence, which is what New Vision of Care is all about. The focus of New Vision and Care will be on understanding the needs of people in need and their carers, which is obviously key, and they're aiming always to move people towards health, wellness, and maximising independence. So, last slide from me, the ideal triangle that we would like to get to, which will enable us to really target resources in the best way, is to have that risk stratification and case finding, link it to individual care planning, which is very much linked to our Share Your Care project, which looks at shared health records across organisations, and then really that clinical decision support, so using something like an interqual tool to make sure that the level of interventions within the hospitals is also absolutely appropriate and the people that are going into the hospitals are the right ones. So the ideal triangle for us to make sure that we've got all of it right will look something like that. last slide for me.
Thank you very much, Eve. Does anyone have any immediate questions at this point for Eve?
Can I just ask a question about the frailty of it, and particularly frailty scores?
Yeah.
Across your system, has everybody signed up to using the frailty scores in the same way, or have you got different scores being used in different ways? Because clearly there's quite a range to choose from.
I think at the moment it's really not systematic. So we're at the tomorrow in fact we're going back to system leaders group with all of the work that we've done, and assuming that the model is adopted and supported by system leaders group, what we'll then be doing is setting up the priority work streams. One of the very first priorities we see is looking at how we use risk stratification, because we've got so much available to us. You know, we've had ECG tools for a while, as I say. We know that we've got access to this frailty index. We know that there are a number of other models. So we want to look at how we are using it and how we can really start to drive the best benefit out of what we've already got. So we see that as a real priority.
Any other questions at this point?